Okay, we've looked at pregestational conditions, and now we're going to be looking at gestational conditions. So what are they and why are they so important? These are disorders that did not exist before pregnancy. The occurrence of these conditions puts the woman and her fetus at risk, and some of these conditions can include hypertension in pregnancy, hyperemesis gravidarum, hemorrhagic complications, surgery during pregnancy, and trauma, as well as urinary tract infection. Let's first look at hyperemesis gravidarum. The definition of this is excessive vomiting accompanied by dehydration, electrolyte Nearly all women experience some degree of morning sickness, nausea, and vomiting during pregnancy, particularly during the first trimester. The cause of nausea and vomiting during pregnancy is believed to be the rapidly rising serum levels of a hormone called HCG, human chorionic gonadotropin, which is secreted by the fetus. Increased estrogen levels have also been implicated. Researchers theorize that during human evolution, sickness during pregnancy protected the fetus by making the mother too nauseous to eat foods that were more likely to be toxic to the early pregnancy. Support for this idea comes from the fact that there are many foods that tend to repulse pregnant women containing potentially harmful substances. Also, women who have virtually no nausea or vomiting appear to be more likely to miscarry than those who experience some sickness. However, too much vomiting can interfere with weight gain needed to sustain pregnancy and cause dehydration, which can be harmful to both mother and child. Extreme nausea and vomiting during pregnancy may indicate multiple pregnancy, such as twins or more, or extremely rarely a hydatiform mole, which is abnormal tissue growth that results from a conception that does not give rise to a viable fetus, or thyroid disorder. The symptoms include the regular symptoms of pregnancy that we've discussed, severe nausea, persistent excessive vomiting, often leading to weight loss, lightheadedness, or fainting. So how do we even detect this? So what we're looking for as far as signs and tests, we look for the signs of dehydration that may include ketones in the urine, increased hematocrit, increased pulse rate, decreased blood pressure, and blood tests may be recommended to further evaluate dehydration, such as electrolytes and BUN. The treatment. Uncomplicated nausea may be treated with dry foods such as crackers and small frequent meals. Emotional support may also help with nausea and or vomiting. It is important for a pregnant woman to maintain her fluid intake. Fluid should be emphasized during times of the day when she feels least nauseated. Seltzer or other sparkling waters may be helpful. Medication to prevent nausea is reserved for cases where vomiting is persistent or severe enough to present potential maternal or fetal risks. The most severe cases may require hospitalization with IV fluid administration. An evaluation to rule out abnormalities of the liver or gastrointestinal tract may be necessary in cases of persistent symptoms. Psychosocial support is an important part of treatment. Most nausea and vomiting during pregnancy is normal, although unpleasant. As far as looking at expectations or prognosis, nausea and vomiting peaks between the 2nd and 12th week gestation and resolves by the second half of pregnancy. With adequate identification of symptoms and careful follow-up, this sickness rarely presents serious complications for the infant or mother. Complications that can arise are social or psychological problems associated with this disorder of pregnancy. If such problems exist, they may need to be identified and addressed appropriately. We're now going to look at gestational hemorrhagic disorders. We're going to talk about nursing interventions for bleeding during pregnancy. So these are some things to keep in mind overall. First of all, call for assistance. You want to monitor blood pressure and pulse, observe for signs and symptoms of shock, count and weigh pads. If she is greater than 12 weeks, check the fetal heart rate, prepare and start an intravenous, prepare exam equipment for the provider, have oxygen set up, collect and organize objective and subjective data in labs, obtain prescription for type and cross match, assess family coping mechanisms, support, and knowledge, and do an ongoing assessment of family response to the situation. Spontaneous abortion, also known as miscarriage. The definition is here: termination of the pregnancy before viability of the fetus below 20 weeks gestation with a weight of less than 500 grams or crown rump length of less than 18 centimeters from natural causes. An early spontaneous abortion occurs before 12 weeks. A late spontaneous abortion occurs between weeks 12 and 20. So there's all kinds of different reasons to have a spontaneous miscarriage. And some of the causes include abnormal embryonic development that occurs in about greater than half, endocrine imbalance, immunological factors, advanced maternal age and parity, infections, maternal disease, poor nutrition, drug use, genetic factors, teratogenic agents, reproductive tract abnormalities, and many are just for unknown reasons. Complications include infection, septic shock, hemorrhage, damage to the reproductive organs secondary to treatment. When we look at care, the woman may need analgesia or anesthesia to help cope with pain. Oxytocin or prostaglandin may be used to augment the passage of tissue, and the patient will receive oxytocin after passing the products of conception or after having a dilation and curettage to prevent hemorrhage. Ergot preparations or prostaglandins may be given after the spontaneous abortion for excessive bleeding. Antibiotics also may be given. We want to refer to a grief counselor. Do not trivialize the loss of her or her partner's baby. If the woman is Rh negative and Coombs negative, she should be given RhoGAM within 72 hours of the spontaneous abortion. Discharge teaching includes if having a dilation and curettage, which is a surgical removal of the products of conception, that someone needs to remain with the woman for the first 12 to 24 hours. We want to report any heavy bleeding, fever, chills, foul-smelling discharge, abdominal tenderness, and we also want to give information about coping resources that are available. And this is just a brief overview of some of the miscarriage types. A threatened miscarriage occurs when we see some bleeding. We have some bleeding, some cramps, some backache, but the cervix remains closed. It may continue to miscarriage or resolve. An imminent miscarriage, the signs and symptoms are bleeding, cramping, the cervix begins to dilate, the membranes may rupture, and they will definitely miscarry. An incomplete miscarriage is they pass part of the products of conception while retaining others, typically the placenta. The cervix is dilated. A complete miscarriage is we pass all the products of conception, the cervix is open for this to happen, but closes after. In a missed miscarriage, a missed spontaneous abortion, the fetus dies in utero, but nothing is passed. Growth ceases, pregnancy symptoms decrease. She may have brownish discharge, but the cervix is closed. Her HCG levels drop, and it can lead to DIC, which we're going to talk a little bit later in this module about what happens with DIC. Recurrent miscarriage is 3 or more consecutive pregnancies We can also have ectopic implantation. And when we look at an ectopic pregnancy, this is a pregnancy that implants outside of the of the uterine cavity. And in the order of the frequency of occurrence, we see it's the ampulla, the isthmus, the interstitium, the fimbria, the tubo-ovarian ligament, the ovary, the abdominal cavity, and also on the cervical os, the external cervical os. So this just shows what where it can implant. The problem with having an ectopic pregnancy is that as the fertilized egg starts to grow, there's no place for it to expand, and it will result in rupture of the tube, which is an obstetrical emergency. In a rare case, an abdominal pregnancy can take. The patients will have, their missed period and such, but you're not going to hear, the uterus is not going to grow the way a uterus typically grows when you're seeing a pregnancy advance. And when we talk about surgery and pregnancy, surgery, this patient will have surgery, and either they're going to remove the tube if it is a tubal pregnancy, especially if the tube is ruptured. But if the pregnancy is intact inside the tube, they try to do a salpingostomy where they incise the tube to remove the products of conception in hopes of saving the tube for further pregnancies. Sorry about that. Okay, on to the next slide, and it was a wrong number. Okay. So we're looking at here, this is actually an abdominal ectopic pregnancy. If it's the second or third trimester, the placenta is attached to vital organs, and which means it's going to look for a vascular source. So any abdominal organ has vasculature, and after delivery, the placenta should not be cut. The cord is cut flush with the placenta, which is left to be absorbed by the body. Pretty freaky, huh? A hydatiform mole, also known as molar pregnancy. There's one of two types of gestational trophoblastic neoplasms. The trophoblastic cells covering the chorionic villi profilate and undergo cystic changes. So the risk factors are women who are undergoing Clomid therapy, early teens or older than 40, higher incidence in Oriental women and women from tropical areas. The risk of having a second mole is 1 to 2%, and up to 20% can develop into trophoblastic pulmonary emboli. So here's the types. You can have a complete mole where the nucleus of the egg has been lost or inactivated and resembles a bunch of white grapes. The uterus is larger than expected for gestation. The mole contains no fetus, placenta, or amniotic membranes or fluid. Hemorrhage and vaginal bleeding occur. 20% show progression to choriocarcinoma. A partial mole is maternal genes do exist. It's a triploid, which is 69 chromosomes, which we know chromosomes occur in pairs, so this is an odd number. It's very rare since 2 sperms simultaneously fertilize the ovum. So there's many congenital anomalies present, less chance of a malignant transformation, less than 6%, and approximately 80% regress spontaneously. When looking at the signs and symptoms, there's vaginal bleeding. It could be dark brown or bright red. They may pass the vesicles, so passing things that look like little bunches of grapes. The uterus is larger than expected for gestation, especially as gestation progresses. Only about 25 have a smaller than expected fundal height. The patient's anemic. There are no fetal heart sounds. She may have hyperemesis gravidarum, and preeclampsia occurs in about 15% of cases, and we see preeclampsia. Here's another little picture of the little cluster of grapes. When we look at management, the woman aborts the little vesicles. The ultrasound shows diffuse snowstorm pattern. We have an elevated hematic HCG level. The patient will have a suction curettage. She may choose a hysterectomy if no further plans for children are or in her future. We can induce with oxytocin and prostaglandins. Induction with oxytocin or prostaglandin is not recommended because she's at a higher risk of hemorrhage. Follow-up exams include serial HCGs for at least a year to watch for choriocarcinoma. Care: we watch for and teach the client to watch for anemia, hyperthyroidism, infection, DIC. She can also get an emboli in her lung from the trophoblast, so have her be aware of shortness of breath. She can get ovarian cysts, and her contraceptive needs must be addressed. After she passes the mole, we will give oxytocin post-delivery to prevent hemorrhage. So we want to make sure we have a type and cross match on hand, and if she's Rh negative and Coombs negative, she will get RhoGAM. Now we're going to look at placenta and cord anomalies. About 1% of singleton, about 5% of multiple pregnancies, that's twins, triplets, quads, quints, have an umbilical cord that contains only 2 blood vessels and is Vasa previa, also called velamentous insertion. A velamentous insertion of the cord is a rare anomaly. It's associated with placenta previa. In multiple gestation, the cord vessels branch at the membranes and course unto the placenta. Rupture of membranes or traction on the cord may tear one or more of the fetal vessels. Fetuses may rapidly bleed to death as a result. A battledore insertion. It kind of looks like a ping pong paddle, doesn't it? What happens with a battledore insertion is just kind of an unusual insertion of the cord into the membranes. They just kind of fold into each other, and typically you can see that the cord is at the margin of the membranes, and that there is an increased risk of fetal hemorrhage, especially centuriate placenta. What this is kind of interesting. It's a little extra lobe, so it's 2 or more separate lobes, each having a distinct circulation. The blood vessels are supported only by membranes and may tear during labor and birth. If one or more of the lobes remains attached to the uterine wall with the delivery of the placenta, the uterus will not be able to contract, and this will increase the risk of postpartum hemorrhage. For the uterus to contract after delivery, we have to have all the products of conception out of the uterus. So if you have a sneaky little extra lobe, that will not allow that uterine involution to occur. A circumvolute placenta. A circumvolute placenta is a double fold of the chorion and amnion, forming a ring on the fetal side. There is an increased risk of late miscarriage, preterm labor, and antepartum hemorrhage in pregnancies that have a circumvolute placenta. So we look at some other placental problems. So some late pregnancy bleeding. We're going to look at abruptio placenta and placenta previa. An abruptio placenta is the premature separation of the placenta from the uterine wall. And it could be a detachment of part or all of the placenta from the implantation site. It accounts for about 15% of all perinatal deaths. The death of the fetus is is usually from preterm birth or intrauterine hypoxia. Between 15 and 30 women with previous abruptions will have a recurrence in subsequent pregnancies. The causes of placenta abruptio placenta include maternal hypertension from any cause, which is identified in about half the severe abruptions, gravidity over 5 pregnancies, so people who are multigravidas, abdominal trauma, dietary deficiency, maternal cocaine use, sudden uterine decompression, is if all of a sudden she, for whatever reason, she's has polyhydramnios, the membranes rupture, and that sudden decrease in uterine volume puts torsion on the placenta and makes it start to abrupt. Anybody with a history of previous abruption and people who are smokers. There is a grading system for abruptio placenta. A grade 1 will see dark red maternal vaginal bleeding, some pain, but usually they have no pain at all. The uterine tone is normal, and neither mother or baby is in distress, and the placenta is about 10 to 20% detached. Grade 2, there is uterine tenderness, pain, and increased uterine tone. The uterus will not relax in between contractions. So we know when we looked at how the uterus works and what goes on, that we really like that uterus to soften up between any kind of contraction, even if the mom is having Braxton Hicks. So this is not allowing the uterus to relax, thus it's not going to allow the placenta to refill. So neither the mother, so what happens with this is you're going to see mild shock with non-reassuring fetal heart pattern because the baby is hypoxic, because we're not getting reoxygenated. When they look at the placenta, it's between 20 and 50% detached. A grade 3, we have severe tetany, so our uterus is rigid, agonizing, unrelenting. This is just showing a clot from an abruption. So when we look at the clinical manifestations with the woman who's experiencing a pregnancy with a placental abruption, it depends on the grade of the abruption. If blood accumulates between the placenta and the uterine wall, it may produce a uterus that appears purplish and bruised with a loss of contractility, and shock is out of proportion to the blood loss. It's diagnosed by symptoms. Ultrasound is used to find a retroplacental mass, but negative findings do not rule out abruption. Advanced ultrasound is able to pick up more cases than in the past. Medical management and prognosis include treatment depending on maternal and fetal status. There is an increased risk of DIC. She may deliver vaginally or C-section depending on what the status of her labor is, how shocky she is, what the grade of the abruption is. Fetal prognosis is poor with grades 2 and 3. About 25 to 35% of the fetuses die. Survivors show an increase in neurological damage. If mom is Rh negative, she may be given RhoGAM. After we've done the Kleihauer-Betke test to make sure that we haven't had a mix of maternal fetal blood. This is one of the cases where it's, you have to think back about pregnancy and mom's circulation, baby circulation, but typically never the twain shall meet unless something invasive happens. That's why we think about it with amniocentesis and chorionic villi sampling, or somebody who has like a trauma during pregnancy, because there may be an accidental mix of maternal and fetal blood. Well, with an abruption, you're lending yourself to more of a chance of the mixing of that blood. So we're going to give RhoGAM only after the Klein-Hauer-Betke test is done to determine the presence of maternal fetal transplacental hemorrhage. So we want to make sure that that's okay before we give RhoGAM. Nursing assessment is going to include frequent vital signs, continuous electronic fetal monitoring, and remaining being prepared for birth. Placenta previa. Placenta previas are kind of interesting. What you see with a placenta previa is the placenta. Think about the placenta as the captain of the ship, right? It's the baby's life support system. It should be the last man out, just like the captain of the ship. Make sure all the passengers are off. That is the last thing out is the placenta. Well, with placenta previa, the captain of the ship is planted either partially or completely over the exit, which is the cervical os. So the placenta is implanted in the lower uterine segment near or over the internal cervical os. It can be described as complete, or it's completely blocking. You can see the picture with the complete, partial. You can see partials, what we also call marginal. And then So now we're going to kind of change gears. We're going to talk about blood pressure issues. Okay, a normal blood pressure is needed to perfuse both the mom, the placenta, and of course the baby. So if we have too low, poor perfusion, so we're going to compromise nutrition and oxygenation. Too high, we have poor perfusion and we compromise nutrition and oxygenation. So we don't, think about back to Goldilocks and the Three Bears. We don't want too much, we don't want too little, we want just right. So hypertensive disorders in pregnancy, what are they? Looking back at the American Congress of Obstetricians and Gynecologists, this is what they defined in 2013. Gestational hypertension is a blood pressure elevation after 20 weeks of gestation with the absence of proteinuria, so there's no protein in the urine or other systemic findings. Chronic hypertension is hypertension that predates pregnancy. Preeclampsia is hypertension with a systolic blood pressure of equal to or greater than 140, or diastolic blood pressure elevated on 2 separate times, 4 hours apart. You must be 20 weeks gestation. Includes hypertension with any of the following: thrombocytopenia, which is platelets that are less than 100,000, impaired liver function with 2 times the normal transaminase, new renal insufficiency, creatinine with a greater than 1:1 milligram per deciliter, or doubling of the serum creatinine, and no renal disease, pulmonary edema, new onset of cerebral or vascular disturbances, and we can also get a superimposed preeclampsia on somebody who has chronic hypertension. So you can have somebody who's hypertense, doesn't mean she's preeclamptic, but she can get preeclampsia imposed on her pre-existing hypertension. So when we look at eclampsia, eclampsia is when we have someone who's preeclamptic and it progresses into having seizures. So the woman is you have to think about it this way. Think of all the increased fluid volume during pregnancy. That's a lot of fluid, right? About 50% increase in fluid volume. When we have this hypertensive disorder, we're going to get vasoconstriction of the maternal vasculature. So we have all this blood volume and we have vasoconstriction, so the pressure is getting higher and higher and higher. So we're bombarding all of our organs with this very, very high pressure. It's insulting the maternal body, this high blood pressure. So we can also insult our central nervous system, and so then this is what causes the seizures or a coma. With most of these ladies, there's no other history of any kind of pre-existing pathology, and this is really important. The eclampic seizures can occur before, during, or after birth. So it can occur during the pregnancy, during the labor process, and into the postpartum period. So our patients who are preeclamptic, once they deliver, we don't think, okay, the stars are shining, the birds are singing, everything is good. No, not necessarily. We still have to watch these women very, very carefully. So if you're working in an emergency room, this is for you people that want to be the trauma gods and goddesses, and you get somebody who comes in and they've recently given birth and their blood pressure is elevated, really be on the lookout, because they can have an eclamptic seizure in your emergency room. This is why I tell people OB is not just for those of us who like working in maternal child areas. You may come in contact with a pregnant woman all kinds of places, especially if you work in ICU. Then if you work in the or the ER, if you work in the ER, here they come via ambulance or via private car from the family, or they have the eclampic seizure and now you've got them in your ICU to monitor. So that's why all this information is very, very good for everybody to know. HELLP syndrome. It's a complication or variant of preeclampsia or eclampsia. It can occur without significant hypertension. 70% occur antepartally in the 3rd trimester. So antepartally means before we've delivered. The maternal mortality rate's about 1%, and the perinatal mortality rate is about 7 to 20%. So what does HELP stand for? H is for hemolysis, which is severe anemia unrelated to blood loss. Because we're not really losing blood, we're destroying blood cells, so it's a different mechanism. E is elevated liver enzymes. It's actually E and L. So the LDH is greater than 600. The AST is greater than 1.2, and low platelets, less than 100,000. 60 to 90% of these ladies will present with right upper quadrant epigastric pain. Why? Because their liver is engorging. This is what's going to be causing their right upper epigastric pain. 60 to 90% present with nausea and vomiting. 82 to 88% are hypertensive, and 33 to 61% have a headache. So when we look at nursing care, our overall goal is the best outcome for mother and baby. So how do we get there? We want to identify the patient at risk. We want to gather subjective data about risk factors. So let's kind of look at some maternal personal risk factors for preeclampsia. So here's our ladies who are more at risk for developing preeclampsia. First, pregnancy, new partner. So maybe mom was divorced, she got remarried, so we have a new partner. This can influence the occurrence of preeclampsia. Our young moms, younger than 18, our older moms, older than 35. A history of preeclampsia in previous pregnancies. A family history of preeclampsia and first-degree relatives. What happened with her mom? Did her sister have issues with their pregnancies? Black race, and obesity, the BMI of greater than or equal to 30, and interpregnancy intervals of less than 2 years or longer than 10 years. So our pregnancies that are spaced very, very close together. So maternal medical risk factors for preeclampsia. So here's a list of the following of the maternal risk factors for preeclampsia. Chronic hypertension, especially when secondary to such disorders as hypercortisolism, hyperaldosteronism, pheochromocytoma, or renal artery stenosis, and these are conditions you'll learn more about in your med-surgery courses. Pre-existing diabetes, type 1 or type 2, especially with microvascular disease. Remember we talked in the pre-gestation conditions about how diabetes can adversely impact maternal vasculature. Renal disease, systemic lupus erythematosus, obesity, thrombophilia, history of migraine, use of selective serotonin uptake inhibitor depressants, SSRIs, beyond the first trimester. So some placental and fetal risk factors for preeclampsia. Here's our placental and So nursing care, more questions. Does she have headaches, vision changes, epigastric pain, or swelling? And we're talking about swelling. We're not just talking about puffy ankles. We're talking about the Michelin Man. We're talking about puffy face. We're talking about sacral edema. We're looking at, a rapid weight gain in a very short period of time. I don't care how much food you're eating. You're not going to gain, 5 pounds in 2 days. That's fluid, folks. So these are things to be aware of. Nursing care, we want to do a really, really good physical assessment. We want to do an accurate assessment of her blood pressure, and sometimes you can't rely on those machines. Those machines are not always good. They pick up artifact. Get good at manual blood pressures. Manual blood pressures are important. So we want an accurate assessment of the blood pressure. If you think, wow, is this blood pressure correct? Recheck it. Assess for edema. Although edema is no longer included in the definition of preeclampsia, many preeclamptic women are edematous. So review how to assess for edema, and your textbook has got some really nice illustrations of pictures of edema. So be really comfortable with that. And we want to check the deep tendon reflexes. Reflex reflect the balance between the cerebral cortex and the spinal cord. Normal reflexes, this is going back to your health assessment, is 2+. This is important to remember. If a patient is hyperreflexic, 3+, 4+, this shows that her central nervous system is very irritated. Okay, we're going to look at labs. We're going to check her urine dipstick for protein. At her CBC, we're going to look special attention to those platelets. Remember what I said about HELLP syndrome, less than 100,000? Where are those platelets standing? Serum creatinine, the liver enzymes, right? We're looking at liver enzymes, HELLP syndrome. We're looking at all of these things. If she's an antepartal patient and we're just observing her, she's not ready for delivery, we may collect a 24-hour urine for creatinine, so you want to check. Typically we have it on ice in the hospital, so we keep it cool. As far as fetal assessment, we want to have the mom perform daily fetal kick counts. We're going to do non-stress testing and biophysical profile. Now to kind of get back to the protein, so how much protein is acceptable? If you have trace, that's okay, but 1+ protein is a diagnostic cutoff for excessive protein in the urine of a pregnant woman. Think about protein, building blocks of the body. We don't want to be losing building blocks, and we sure don't want to be peeing out our building blocks, so this is real important. If a woman has worsening hypertension during pregnancy, we want to restrict her activity. We want to do fetal surveillance. We're going to be doing our electronic monitoring, and she may need to start on oral antihypertensives. So a woman with hypertension and suspected preeclampsia is hospitalized. We're going to monitor her vital signs, her deep tendon reflexes, her fetal heart rate, and her breath sounds. Right? We want to make sure that she's not going into pulmonary edema. We don't want gurgly breath sounds. Nice, clear breath sounds. I and O. Where's the fluid going? What's going in should be coming out. We're going to monitor those labs, looking at the CBC, looking at the platelets, looking at the liver enzymes. We really do want to have a seizure precautions just in case she tips the scale and goes into eclampsia. So we want to have suction, oxygen, and a call light in reach. We want to have a non-stimulating environment. So we don't want to do anything that's going to irritate her central nervous system. Keep the room on the darker side. Limit visitors. If she's kind of embarrassed about telling her family they all can't be hovering around, it's okay for us to be the bad guys. As I've said before, they're not my relatives, they're not my friends. If they don't like me, that's okay. I'm protecting my patient. And we want to do medication management. So let's look at some of the medications. Medications to be familiar with. This is an interesting look inside. Is labetalol, also known as Normidine, hydralazine, which is a Preslin, and methyldopa, an oldie but goodie, also known as Aldamet. So when a provider places a woman on antihypertensives, many factors are considered. How pregnant is she, if the drug crosses the placenta, what other options are available. You always look at potential harm to the fetus is what worries most providers. When looking at meds, always look at the benefit versus the risk. That's how the decision is made. The goal of medicating somebody is to get their blood pressure down to a safe range, but we don't want it too low because then we're not perfusing again. Remember, too high we're not perfusing, too low we're not perfusing. Methyldopa and hydralazine are the choices for women needing medication for hypertension who wish to breastfeed. So those are safe breastfeeding medications, and it would behoove you to look at those medications and be familiar with those medications. Magnesium sulfate. Magnesium sulfate is an interesting medication. And I'm just going to kind of read this little blippy tube at the American College of Obstetricians and Gynecologists in the Society of Maternal Fetal Medicine. Continue to support the short-term, usually less than 48 hours, use of magnesium sulfate in obstetrical care for appropriate conditions and appropriate durations of treatment, which include the following: prevention and treatment of seizures in women with preeclampsia or eclampsia, fetal neuroprotection before anticipated early preterm, less than 32 weeks of gestation, short-term prolongation of pregnancy up to 42 hours to allow for the administration of antenatal corticosteroids in pregnancy between 24 weeks of gestation and 34 weeks of gestation for women who are at risk of preterm delivery within 7 days. And that's just from ACOG's 2013 committee statement. So let's look a little bit more at mag sulfate. We're trying to prevent and treat seizure activity. Magnesium sulfate is not, and I repeat, not an antihypertensive. Its use is indicated in severe preeclampsia, HELP syndrome, and eclampsia. And also I have a little parenthesis here, we can use it in preterm labor. Its mechanism of action is unknown. If you think about back to when you took biology way back in the day, and those of you who were biology majors, how magnesium and calcium exchange places in the cell. So we know calcium causes muscles to contract, magnesium causes muscles to relax. That's probably the best way I can explain why we think this works, because it's going to relax things. It is excreted by the kidney. So how does this influence our nursing interventions? Okay. Think back to Goldilocks and the Three Bears. If we're going to run magnesium, we're running it too little is not good. We want the level just right. Too much is not good, right? Remember I said it kind of depolarizes things and relaxes things. I mean, suppose we get really relaxed. Well, is our diaphragm not a muscle? Do you want your diaphragm overly relaxed? No, breathing is good. We like breathing. I'm a big fan of breathing. So it's important that we know how are her kidneys working, because we want her to be able to excrete the magnesium. We want to see at least a 30 milliliter per hour urine output. So these women are on strict INO, and they'll have like a little extra meter inside their urine catheter bag that'll allow us to look at little tiny measurements of urine. We want at least 30 mils an hour, if not more. So we're going to really be watching that INO. So that's why, this is how it influences the nursing interventions. So excreted by the kidneys, we're going to be looking at her respiratory rate, if we have too much, and we want to make sure she's putting out 30 milliliters of urine minimum an hour. We administer an IV piggyback. We talked about IV piggybacks when we talked about insulin at the lowest port. We do give a loading dose of 4 to 6 grams over 20 minutes, and then we run a maintenance IV infusion of about 2 grams an hour. Our therapeutic serum levels 4 to 8 milligrams per deciliter, and there is some side effects. Everything that has an effect has a side effect. So we may see flushing, hot flush. Let's think about the interplay between magnesium and calcium one more time in the cell. Calcium causes the muscle to contract. We are displacing it with magnesium. So we want to monitor the patient for respiratory depression, and the antidote for magnesium sulfate is to give calcium. So calcium gluconate or calcium chloride. This is done doing cardiac monitoring, because if you give it too fast, you could put somebody into cardiac arrest. So it isn't like, oh, we're just going to give this little antidote like giving somebody Narcan and life is good. This we have to really monitor a whole lot closer. So nursing care for a patient receiving magnesium sulfate, vital signs every 15 to 30 minutes. Monitor urine output. Why? Ding, ding, ding. It's excreted by the kidney, and we don't want our mom to get mag toxicity. We want to monitor the reflex, safety, provide a quiet environment, side rails up, oxygen and intubation equipment, and antidote available, and document all of your nursing interventions. There is only one cure for preeclampsia: delivering the baby. Some nursing care for the women receiving magnesium sulfate, some other things to just kind of be aware of. Report any blood pressure where you have greater or equal to a systolic of 160 millimeters of mercury or 110 millimeters of mercury diastolic. Respiratory rate. This is important. Remember this. Respiratory rate. Any respiratory rate less than 12 breaths per minute. The diaphragm is a muscle. We're big fans of breathing. Respiratory rate under 12 needs to be reported. Urinary output that's less than 30 milliliters an hour. If your patient is developing headache, visual disturbances, decreased level of consciousness, or epigastric pain, report immediately. Increased in or loss of DTRs. Again, we can mag-tox somebody out and knock their deep tendon reflexes out. If we see more edema, if we see increasing protein in the urine, or any other abnormal labs. So our goal is to have the healthiest outcome possible for our moms and our babies. And that's why gestational conditions are so important for you to learn about. If you have any questions, feel free to ask or put your questions up on the discussion board. Thank you. More gestational conditions are continued in part 2 of this discussion.